Again, good morning, folks, or good afternoon. This is Jason Stubers, your webinar host. Thank you for joining us today. Please drop your name in the chat as well as where you are calling in from, and we will get started in just one moment. All right, looks like we have most people in the room. Okay, we are going to get started. Good morning and welcome to this morning's live national webinar, Solving the Mysteries of Palliative Care with our healthcare experts. I am Jason Stubers, Senior Strategy Manager for Compassion Choices, the nation's oldest and largest nonprofit dedicated to improving care, expanding options, and empowering everyone to chart their end-of-life journey. Before I introduce today's speakers, there are a few housekeeping items I would like to share before we get started. If you indeed need live captioning in either English or Spanish, please enable it at the bottom of the screen by clicking on the double C's and follow the prompts. There will be a brief 10-minute Q&A at the end of the conversation, so please pre-populate your questions in the Q&A function located at the bottom of your screen, and we will get to as many of those questions as the time allows. No need to raise your hand as we are in the webinar format. We will only take questions from the Q&A function. And lastly, this webinar is being recorded and will be sent out post the webinar if you would like to view it again or share it with those in your network or community. With that said, I am honored to introduce to you today's panelists, Compassion Choices National Medical Director, Dr. Susan Wilhoit, and National Director of Clinical Engagement, Jessica Empeno. Our moderator for this morning's discussion is President and CEO Emerita, Kim Callinan. At this time, I would like to turn it over to you, Kim.
Wonderful. Thank you so much, Jason. And I'm so delighted to be here today with Dr. Wilhoit and Jessica, my amazing colleagues, for what will be my last webinar on staff at Compassion and Choices after a decade of working at the organization. So I'm going to try to make this one really good and go out with a bang. And fortunately, I'm with Jessica and Dr. Wilhoit and Jason, and so you have some incredible people to hear from. I thought I would start out this call today sharing with you a story that comes from a woman that I met when I was speaking in Florida at a community center. Her name is Janina Bertolo. And at the end of a presentation that I gave around finishing strong, she stood up in the audience, thanked me profusely, and then asked whether it would be appropriate for her to share her story about how palliative care had transformed her life. Of course, I obliged, and here is what Janina said. She said, following a mild case of pneumonia in the summer of 2016, her husband, Gary, and she took a long-planned cross-Canada trip in September. About midway through it, she caught a cold. Suddenly, she couldn't walk across her hotel room, and she would run out of breath. She twice visited a clinic in Canada where a doctor suggested she didn't have asthma, but likely also some form of COPD, which is an umbrella term for chronic lung disease. When she returned home, her doctor referred her to a pulmonologist who diagnosed her with emphysema, and the test showed that her lung function was about 33% of normal. Over time, her condition worsened. She was an actress, and by the spring of 2020, she had to stop performing because she didn't have sufficient breath. The lower lobe of her left lung was slowly hyperinflating, which impacted the rest of her body as it started to push on all of her other organs. By 2022, she had developed terrible constipation, she struggled to sleep, and she needed oxygen 24/7. She had lost nearly 20 pounds because she had so little room in her stomach. And then by late 2022, her lung function had deteriorated to about 23%. She met with an attorney to finalize her financial and end-of-life plans, and she began giving away all of her possessions. She was in constant discomfort and anxiety, and very discouraged over how small her life had become. At her annual checkup in the fall of 2022, She went through all of the symptoms that she was feeling with her primary care provider, and he suggested that she see a palliative care professional. And she was shocked. She'd always thought that palliative care was only for hospice patients. And she knew from her pulmonologist that she was not yet terminal and that she still had more than 6 months left to live. She also thought that palliative care was simply about pain relief, and she wasn't actually in any pain. Her provider explained to her that palliative care is open to anyone dealing with a life-limiting or terminal illness. It can be used concurrently with other treatments, and it deals with much more than physical pain. It turned out that palliative care for her was a godsend, and she was able to return to a life where she was able to live meaningfully, and the symptoms of her disease were no longer controlling her life. I am so glad that you're all here today to share the importance of palliative care and to understand what it's about, because my hope is that this story will inspire everyone to talk with their providers about palliative care if you have some type of a life-limiting illness. For her, this was the start of getting her life back. And she is still alive to this date, as far as I know, with many very meaningful quality of life, able to return to her normal functions. Our work around empowering everybody to chart their own end of life journey is about making sure that people are aware of the full breadth of options. And palliative care is something that's available to people actually not just at the end of life, but throughout one's life. And we wanted to be sure that people were aware of this so that those diseases that are limiting your desire to keep on living, that you have the potential to see whether palliative care is a potential solution that can return meaningful quality of life to you. I'm here with two experts today, Jessica Empeno and Dr. Susan Wilhoit, and they're going to discuss the ins and outs of palliative care. Dr. Wilhoit is a palliative care professional herself, and Jessica is a social worker who's worked within the field of palliative care for many years. So I'll start first with Dr. Wilhoit. There are so many myths and misunderstandings about palliative care. Can you just start by simply explaining what palliative care is and what it provides?
Yes, absolutely. Kim, thank you for that story. I think it illustrated really well. And you actually explained it so well what palliative care is. And I think of palliative medicine as a specialized form of care that takes care of the whole person. So families, loved ones, the person. And it's about offering relief of suffering of any kind. So suffering can be pain, certainly people associate with pain, but it can really be shortness of breath. It can be anxiety. So palliative care really tries to focus on the symptoms of someone's disease or the symptoms that someone may be experiencing because of their illness. In palliative care, we come together as an integrated team, hopefully. So you'll have nurses, social workers, chaplains, physicians, all working together, collaborating to try and make your life more meaningful for you. So if you're facing a life-limiting illness or you're at any stage of the disease process and are having a significant symptom burden that's impacting your quality of life, palliative care is one way you can get support and try to regain that quality of life that's meaningful for you.
And Janina was under the impression that palliative care was a part of hospice care, and it had to mean that she was dying in order to be able to access it. And I think this is one of the common myths. Can you talk a little bit about one, why there's so much confusion around that, and two, like, what's the truth? What's the reality?
Yeah, I think it's interesting. There's a lot of confusion, even in the medical field. It's really frustrating sometimes as a physician when I'm speaking to other physicians and I say, hey, I think this person could really benefit from palliative care, and say, oh, we're not ready for that yet, thinking that it's maybe something like hospice. And so if it's okay, I'll start with just explaining what hospice is. And so hospice is a really beautiful, inclusive focus of care when someone has a prognosis of 6 months or less, meaning that they're terminally ill and they're expected to die from their disease likely in the next 6 months. And that, again, is going to be an interdisciplinary, multidisciplinary level of care. So again, social support, chaplaincy, nurses, physicians, and really trying to usher somebody through their end of life experience. And so at that phase with hospice, a person's no longer receiving treatment for the diseases that they're suffering from. hospice is also, like palliative medicine, experts in symptom management. And so palliative medicine and hospice, that's a big wonderful overlap, is this focus on symptom management and the expertise of managing symptoms. The overlap also is with quality of life and maintaining and optimizing quality of life. The deviations are that with hospice, you're no longer able to receive disease-specific treatment, because the idea is that you've accepted your end-of-life experience. This is the reality that you're in now. You no longer want to return to the hospital. You want the care brought to you, and you really truly want to focus on what the end-of-life experience can be. In contrast, palliative care can be, as you said, Kim, can be offered alongside, in parallel with any sort of life-limiting illness. An example, and for me, is I had a gentleman he was a young person. He was 34 years old when I cared for him, father of 4, and he had esophageal cancer. And he had stage 2, thankfully, stage 2 cancer. But the treatments were so harsh that it actually significantly impacted his quality of life, his ability to swallow, his ability to take in nutrition. And so we saw him in our palliative care clinic to try to help with the symptoms, not as much related to the disease itself, but to the treatments. And so that's where palliative care can really be helpful at any stages of the disease process, that it's intended to focus on the symptoms and the whole person that might be suffering with any sort of life-limiting condition.
Yeah. So what it sounds like to me as a lay person is the kind of care that you receive may be similar, and the focus on quality of life being important, and symptom and burden relief is the same across them. And what's really different is with palliative care, you don't have to give up curative treatments, and you're not as far along in your disease trajectory and may still have years of life left to live. Whereas with hospice care, you're really at the very end. And of course, there are some differences because we live here in costs, which we'll get into a little bit later on sort of how they're covered and what's paid for in terms of insurance. And we'll get to that a little bit later. But I wanted to turn it over to Jessica now. Who has decades of experience as a social worker, really helping patients to be able to navigate the ins and outs of our healthcare system, and talk a little bit about, like, where does somebody get palliative care? Where can they access it?
This is a really great question, but unfortunately, there is not one clear, simple answer to this question, because it really does vary by community. Even within some communities, there can be a lot of different options. So palliative care is most frequently available in the hospitals. Most hospitals around the country do have an inpatient palliative program, meaning they offer palliative care usually through a team, and those teams can look a little different depending on how the hospital decided to set up their program. But most hospitals will have a palliative program, like Dr. Wilhoit described, where they can come in, they can see the person while they're in the hospital and really support them, help developing a plan for going home, and so on. Some places, like Dr. Wilhoit mentioned, are fortunate enough to have a clinic, a place where people can go to get that support. And what we also see in the community is what we call community-based palliative care. So this is where palliative care comes into the home. This is my favorite type of palliative care. When somebody's in a hospital, it's a very different situation than when they're in the comfort of their own home. And so those types of programs are in the community. Unfortunately, those are a little harder to find because of the logistics involved in providing care in people's homes.
Yeah. And maybe to help explain sort of why these are different, this might be a good opportunity and moment for you to talk a little bit about health insurance and kind of how is hospice covered versus how is palliative care covered. And that may explain a little bit about the differences between the two services.
Yeah, so it's a great question, because hospice is a Medicare benefit. Medicare very clearly defines this is what you get when you elect the hospice benefit or when you sign up for hospice. And these are all the services you can expect. And fortunately, hospice is one of the last great benefits of Medicare that covers everything that is provided by hospice at 100%, no co-pays. So all of the services that are described as being part of hospice are paid for, and the family doesn't pay anything. And that's amazing, right? That we don't see a lot of that anymore. With palliative care, though, the benefit is not as clearly defined. And so part of it can be how the program itself is set up. But some of it is also what that particular insurance provider covers. So most insurance plans do have some sort of palliative benefit. The trick is we have to find out exactly what your benefit is through your plan. You know, Medicaid, I think, is a great example because Medicaid generally will cover palliative care, but because most people aren't getting their benefits directly through Medicaid, right? You've chosen an HMO plan to get your benefits through. Those plans will have different programs. So you have that part of it that is really shaping the way that people receive palliative care. And then because of the differences in how programs get paid for the services they provide, you also have variation in how their programs are set up. So for example, you may have a program where the palliative service that's provided is primarily through a physician or a nurse practitioner who are providing those consultations, because the benefit to bill insurance for the reimbursement of that care is a lot more clear-cut and defined versus the full comprehensive team that we hope to see, that we love to see in palliative care. Is not as clearly defined. So the best way to find out, there are some great resources in how to find palliative care in your community. And our team will share those links with you of how you can do a search to see what hospitals have programs, what community-based programs there are. The best way is to, one, either call that palliative program and ask them, do you accept my insurance? And what can I expect? What kind of co-pays do I have? Because believe me, they know what kind of insurance coverage they can bill for, and they'll be able to guide you through that. The other thing is you can call your insurance company and say, I'm interested in this benefit. Can you tell me what my benefits are, what my co-pays might look like, and who are providers that are contracted with you so that I can reach out to them and see about services for myself.
Yeah. Now, I know about a year ago, my mother-in-law has dementia right now, and I was on the phone with my sister-in-law, and we had a conversation about her asking about whether palliative care was an option for her mother, and it turned out it was, and they got some really good services as a result of it. Can you talk a little bit about how common that is for palliative care to be used with dementia, and what are some of the kinds of services that someone might be eligible for, recognizing that there's no federal benefit around palliative care, so it's going to be very state specific. But they live in Louisiana, which is not known as a particularly forward thinking place around medical care, end of life care, and they did get some good services around palliative care. So I think it's probably more readily available in many places than people realize. So you talk a little bit about that, Jessica?
Yes, I absolutely love palliative care and that support for people that are living with dementia, not only for the person that has the diagnosis and are experiencing the changes, because there are so many symptoms and changes that accompany that journey through dementia, but because one of the other elements of palliative care that we haven't touched on as much is the support for the family, for the care partners, for the loved ones. A palliative care, whether it's a physician or a whole team, they really focus on sitting down with everybody and saying, what do you need? What can we do to support everything that's happening, right? Because when a person is dealing with a serious illness, it doesn't just affect them, right? It affects everybody. It affects the whole family. And dementia particularly affects the whole family, right? We call it a family disease for that reason. So palliative care for a person living with dementia is a wonderful benefit to support the changing symptoms that they will see, the progression of the disease that is inevitable. But sometimes even more so, it's the support for their family and their loved ones around them to be able to get them connected to resources, to provide them with that counseling and that emotional support, very practical resources that can be really challenging to coordinate. Palliative care is a wonderful resource for just coordinating all the care and managing all the different elements of living with an illness. So it's not something that I think is used enough for people with dementia, but it is a wonderful, wonderful resource.
Yeah. And I can say with my mother-in-law that they got some really good support that was desperately needed by my husband's sister. And then there was a pretty seamless transition into hospice care where they were actually able to keep the same care team that they had built a relationship and trust with. So it served a couple of really good purposes, I think.
I think that's perfect. And that's one of the things that we love to see. And I think why sometimes there's a confusion because we see so many palliative and hospice programs under the same roof, right? Because a lot of times palliative care, people on palliative care do eventually, it could be months, it could be years, but they do eventually transition to hospice. And so when you can have that smooth transition, maybe the same team, the same organization, it really does help coordinate the care and just make things a lot smoother for everybody. So that's great.
And Dr. Wilhoit, we've been talking a lot about how there's no one size fits all for palliative care, and it depends on the area that you live in, what will be available. Are there options then for telehealth? Say someone lives in a really rural area and there's not a hospital within a reasonable distance to them, and there isn't in-home palliative care. Like, is telehealth an option at all for palliative care, and how would that work if it is?
I would love to say yes, it is. And the reality is it can still be very difficult to access based on where you live and what insurance can cover, and actually even how the home-based or the virtual or telehealth palliative medicine programs are licensed. So maybe they're not licensed in the state where you live. So it can be really tricky, but it doesn't mean that people shouldn't try. And so the truth is, there's that website that Jessica shared. I think earlier it was shared the link about getpalliative.org. That's one way to try to find some. The other way that I've actually had patients be successful with, and actually other colleagues in other states in smaller places have told me just Googling telehealth palliative medicine. And there are companies out there. And so there are resources on the website, on the web, I should say, if you Google telehealth palliative medicine. But the reality is it can still be very tricky to access in smaller places. And even in larger places, it can be difficult to access. It's not a very well-funded program, generally speaking, palliative care. And so it can be tricky to access, unfortunately.
Got it. So I know there's a lot of questions I've seen coming in. I haven't been able to read them all. So I'm going to turn it over to our fantastic moderator, Jason, to go ahead and start asking some of the questions from the audience. Jason, you want to take us away?
Yes, thank you, Kim. Okay, so the first question is, are there hospitals that have no palliative care?
Let's go ahead, Dr. Wilhoit.
I was going to say, I just actually was listening to another talk about this specifically. And so the most recent data that we have is from a 2019 study that kind of gave a palliative care report card. And it sounds like 72% of hospitals that have 50 beds or more in the United States do have a palliative care program. That program can vary. So it could be a nurse, it can be a social worker, it could be a physician, it could be the combination of those things. It can be any of those things independently, as I said. And so it does sound like 72% of hospitals with 50 beds or more, so that's typically smaller hospitals in rural places, are more likely to not have palliative care.
Great, thank you, Dr. Wilhoit. And this next question probably goes to you as well, maybe with some input from Jessica too, do curative doctors sometimes resent palliative care doctors or resent palliative care doctors and see them as interfering? What can patients do to help in this situation?
Well, it's such a kind question because I feel like I don't want the patient to have to feel as though they have to help when they're already facing a difficult situation. And yes, the answer is yes, that can certainly happen. I've certainly had physicians not want palliative care involved. I've had, even in my own family's experiences, I've had situations where the physicians don't think, quote, we're ready for palliative care. That said, I will say that there are also wonderful collaborative oncologists out there, neurologists, cardiologists that really are open to partnering with palliative care. They appreciate palliative care. So again, kind of like all of the answers that we're offering here today, yes and no. And so yes, there are doctors that resent it. And so in terms of what can patients do, I think one of the most important things and roles I have as a palliative care doctor is to be a patient advocate. And so I always try to encourage patients to really advocate for themselves and feel empowered to say, no, I really, I think it'd be really helpful for me. I understand that maybe you don't think it's time yet, but please go ahead and submit a referral so I can at least check it out. I'd like to know what my options are. And that's completely fine to do, and then in terms of what can patients do also, I don't want them to ever feel that they need to do any sort of mediation. A big part of what I try to offer if I come up with a difficult situation with a physician that's not interested or is resentful, if you will, of the idea of palliative care involvement, I really just try to understand where that person's coming from and really partner with them in the best way possible in advocacy for the patient.
Thank you so much. Anything that you wanted to add, Jessica, there?
I think Dr. Wilhoit really said it all. I think it's one of those things that not everybody understands truly what it is, right? A lot of people think that palliative care is just a euphemism for end-of-life care. So it unfortunately requires a little bit of education and explanation sometimes, but that is what we're here to help with.
Great, thank you. Okay, so the next question is, please talk about the connection between palliative care and VSED.
Well, I think I can start. Yeah, I think I can start, and then maybe Dr. Wilhoit can kind of elaborate and take it from here. So VSED being the process that it is, and knowing that we can anticipate a variety of symptoms throughout that VSED process. Everybody's experience is unique, but what we do know is that everybody who makes that choice for VSED is going to experience some symptoms, might potentially experience some discomfort. So palliative care.
Jessica, can you define for everyone what VSED is, just in case?
Oh, yes. Thank you.
Thanks.
Thank you for reminding me to do that. I'm so sorry. So VSED, VSED, stands for voluntarily stopping eating and drinking. And so it is an option for end-of-life care for somebody to make that decision to basically stop eating, drinking, nutrition, hydration, however they're receiving that nutrition and hydration, to stop that as a way to control the manner and timing of an anticipated death. So a lot of times we see this be an option for people who we know they're living with a terminal condition such as Alzheimer's disease or ALS, something like that, but maybe they're not quite yet at that 6-month criteria. They might be, but they might not be at that 6-month criteria that would also make them eligible for hospice. And so it is a choice to, stop that nutrition and hydration. And so in doing that, like I said, there is a process then that the body will go through in that natural progression of shutting down. And so there can be some discomfort there. And so palliative care can be a really great source of support, not only for the physical symptoms that the person experiences, but again, for that emotional support, helping to coordinate the care with the family and the loved ones. Also, because we know that VSED will indeed lead to death, hospice is also sometimes the preferred option. So it just depends on what a person prefers and what they choose and what support feels good for them in that process. Dr. Wilhoit, did I leave anything out? Anything you would add?
No, I think I would add one thing. I think fit beautifully, unsurprisingly. I would say too that if in the consideration process, when someone is considering their end of life options and they have the capacity to make decisions for themselves, and they're just trying to process and understand the road ahead for them, and they want to chart their course for themselves, I think engaging with a palliative care team ideally before you make a decision is really important, because it gives you the chance to really explore all of your options. It helps, if there are symptoms that are just ruining your life, maybe palliative care can really help mitigate those symptoms and kind of shift your focus. But I think it's just an opportunity before you initiate the voluntary stopping eating and drinking process, to understand the whole picture, all of your options, and meeting with palliative care could be helpful for that.
Great, thank you, Jessica and Dr. Wilhoit. This next question, I think maybe all three of you might have some input on. And the question is, do end-of-life doulas have a role in palliative care?
I mean, I can start. So an end-of-life doula is not a clinician. I'm actually an end-of-life doula. So they don't hands-on play a role in palliative care because they are not themselves a clinician. However, if they're knowledgeable, depending, because a lot of times as an end-of-life doula, you might help someone with advanced care planning long before they're terminal, and you might build a relationship with them. So I would think the role that they might have is simply if they notice that someone is having some symptoms that aren't being managed and they have some type of a serious disease, is recommending to the person that they seek palliative care. But other than that, they're not a clinician, so they should not be providing any direct kind of palliative care themselves. Does Jessica or Dr. Wilhoit anything that I said that's not accurate or that you want to clarify?
No, I would just add to that I think in addition to the planning, doulas, depending on their specialty and depending on the needs of the person and their family, doulas are an amazing source of support. So they can be that care coordinator, right, to help manage all of the appointments and the different people coming into the house and all of those kinds of things. But they also are just such a grounding and centering presence to really provide that emotional, sometimes spiritual support for an individual. Unfortunately, we don't see a lot of doulas as part of an established care team, either in hospice and less so in palliative care. But if an individual is working with a doula or they would like the support of the doula, they absolutely can choose to bring in a doula on their own and make them part of their care team.
Anything you wanted to add, Dr. Wilhoit? No, I can't say enough about how wonderful doulas can be and the support that doulas can offer. And I would, anyone that can, unfortunately, it's like a lot of things, it's a matter of resources and access. If people are able to have the resources to access and hire a doula, I think that at any stage of your disease process, it can be so important, because I think when we're facing terminal illness or facing a life-limiting condition, the more support, the better. And specifically the support from people who are going to be more objective and are going to be able to also, as Jessica said, help guide the process. And I think if you can have a doula at any phase in a life-limiting condition, I would strongly encourage it. I'm also an end-of-life doula and really believe in the idea of additional support when you're facing a really difficult time.
Great, thank you, Dr. Wilhoit, Jessica, and Kim. Dr. Wilhoit, this question is for you. Can a palliative care physician be a patient's primary physician for a patient in assisted living?
Oh, it's a great question. And not that I've never ever seen, I don't want to say no, but I've certainly never seen that. So typically a palliative care physician is going to be an adjunct, kind of an additional layer of support, but would not serve as the primary care physician for that individual. And just as a side note, in the hospice and palliative care education, medical education, any type of physician can actually go into palliative care and hospice. And so you can be an emergency room physician, you can be an OBGYN, you can be a critical care doc, a surgeon, and find an interest and an appeal towards this aspect of care, of end-of-life work with palliative care and hospice. And so I say that just so that way folks understand that the palliative care physician that they're seeing may not be a primary care doctor initially. Maybe they were a different type of doctor at first.
Great, thank you. This next question states, what were the key differences for the woman Kim described in her opening story between the care she had been receiving and palliative care? In other words, what were the transformative elements?
Mm-hmm. Wow, you're going to make me rack my brain. She was having difficulty, I believe, with, and she was having to breathe 24 hours a day on an oxygen machine, and the palliative care physicians were able to recommend something that was more portable for her so that she wasn't like tied down to the machine. And then eventually through some therapies they gave to her, I think she was able to move off of the machine altogether. So I know that a big part of it for her was this reliance on this machine and being able to move off of that. I don't know from Dr. Wilhoit, from listening to the story of kind of what was wrong with her, if you have other things you suspect that palliative care did for her.
Yeah, I mean, especially with the COPD, the lung disease that you described, the most common symptom is going to be shortness of breath. That can, and as you said, in this person's case as well, impacted her quality of life, impacted her anxiety. I mean, breathlessness is, I think, I've heard from patients, they fear that more than pain. That idea of not being able to breathe. It's terrifying, I think, for any of us. And oftentimes it's so debilitating that you can't do the most basic things, not to mention the things that you really want to do and enjoy. And so one of the best ways to treat the breathlessness, the best way to treat the breathlessness associated with COPD is going to be a very low dose, typically of some sort of opioid, a short-acting opioid for intermittent, kind of on the spot shortness of breath needs. But then ultimately, oftentimes a longer term, longer acting opioid too. Just again, these are small doses. And it's really interesting, certainly not to go into a whole tangent about the opioid crisis, but there's certainly obviously an opioid crisis out there. But just to remind people, opioids got their start originally in the cancer world, but certainly have a huge role in palliative medicine. And so if your palliative care doctor recommends that for something like breathlessness, I just want to reassure you that the doctor that's prescribing it has specialized training in this and is really focused on your safety as well as managing the symptom. But typically with the COPD, I would guess a little low dose opioid that it just takes away that sense of suffocation. And people, I mean, I can think countless patients that have had just this whiff of an opioid and they're able to go out to the garden, whereas before they were just stuck inside. So I think it can really be transformative.
Yeah. And she definitely talked and when I saw her, she was not on a breathing machine, talking perfectly fine. She spoke in front of a room of 100+ people. And she had talked about how one of the losses she had was that she was previously an actress on the stage and that she was having so much difficulty breathing, she could no longer do that. And then, 24/7 on this oxygen machine. So my guess is that that's exactly what happened for her. Thanks, Dr. Wilhoit.
Great, thank you, Kim and Dr. Wilhoit. Jessica, there are a few questions, and I know that you touched upon this in the formal moderation by Kim, but there are a few questions about palliative care, how it's paid for, is it covered by Medicare or Medicaid? Can you just touch on that again to help answer some of these recent questions on that?
Yeah, so just to kind of recap a little bit, most insurance plans do have some sort of palliative care benefit. The specifics of which really it's best to contact your insurance provider to find out the details, the specifics, and what sort of deductibles or co-pays you can expect. In some ways, the palliative care benefit might be similar to a home health or a hospice benefit, meaning that it's all inclusive and it's, kind of set at a daily rate for all the services. And on some plans, it might be more kind of like a specialty doctor visit. So it would be like going to see your oncologist or your neurologist, right? Where it's billed as a specialty visit and your copay might be the same, flat $25 or whatever it is amount like you would go see a physician. So it can vary. There is no kind of one standard. So the best thing to do is to call your insurance plan. The other thing that you can do is reach out to a palliative care program that you are interested in their services. And believe me, they will be able to tell you what their coverage is, what they provide, and what insurance plans they work with. So that is also a really great way, saves you a little bit of that research. Let them do that research for you because their intake specialists will absolutely be able to help with that.
Great. Thank you so much, Jessica, for helping to kind of recap on to help answer some of those questions. Dr. Wilhoit, can you talk more about the types of patients / diseases that are appropriate for palliative care? We have a lot of hospice services, and it sounds like if a person doesn't qualify for hospice yet, that palliative care would be helpful. We do need more options in rural areas.
Yes, and absolutely right about needing more access in rural areas throughout all aspects of medicine. So I think even primary care is challenging to access in rural America, unfortunately. So the types of, I don't want to say these are the exact diseases, because I want to really emphasize it's the idea that anyone with some sort of chronic or life-limiting illness at any stage, typically in the later stages of that illness, that somebody with a chronic or life-limiting illness. And so those examples would be congestive heart failure as a classic one, the chronic obstructive pulmonary disease, or COPD is another one. We used to think of COPD as emphysema and bronchitis, and now they've been given this kind of umbrella term for an obstructive airway disease. Other pulmonary issues, so lung issues like pulmonary fibrosis is another one that can really be debilitating and impact quality of life. Liver disease, so liver disease unfortunately has a lot of symptoms. It's very fraught with symptom burden. And so anyone with any sort of complication relative to a liver disease it certainly would benefit from palliative care. Obviously cancer, with the diseases I mentioned just now, with like the lung diseases and the heart diseases and the liver diseases, those are typically going to be, palliative care is going to be more helpful in the later stages, because it's in the later stages that people tend to experience more symptom burden. In fact, in some of the classifications, for example, with heart failure and COPD, the classifications somewhat depend on the symptom burden itself. And so that actually speaks to the severity of someone's illness. And so for those diseases, it's typically going to be beneficial, and we'd encourage palliative care later in the disease process. Versus, like I mentioned before, I had a gentleman that esophageal cancer in stage 2, that's not a stage 4 cancer, it's not a stage 3 cancer, it was a curable cancer, and he was cured of it, thank goodness. But the treatments for it were so harsh, so caustic to his body, that he really did need this extra support with being able to take medications, pain control, be able to even eat, as I was saying, and the swallow function impairment. And so with cancer, it's going to be really, I think, at any stage, I would encourage someone that's experiencing symptom issues related to the treatment itself. Other diseases, certainly, as Jessica shared so beautifully, I think with dementia, I think palliative care can be incredibly helpful in especially helping families and patients understand the trajectory. And so I think that there's so much I see with dementia that is just not understood by the patient, by the families. And if we could just sit down and have a conversation with folks and kind of lay out, like, hey, these are the kind of typical things that we see over time. So just to give them a little bit more of anticipatory guidance, I would say, that could be another resource. Any sort of neurologic condition, so Parkinson's disease, ALS, I could go on and on, I'm sure, about the diseases, but just think about any sort of life-limiting condition from which you're likely to die of that condition as it takes its normal course. And perhaps you're not in the end stages of it. You're not in that terminal 6 months or less stage. But really, any sort of life-limiting condition from which you're expected to die should be a reasonable resource, or palliative care should be a resource for them.
And if I could add to
Thanks, so.
that, the other thing I would just say is that sometimes that diagnosis, that what disease we're dealing with, is not always clear. So don't feel like you have to be limited by a certain diagnosis. There are some palliative care programs out there that will say that they are for cancer patients, or that they are for people with heart disease. But generally, palliative care is for anybody where their changes in their health is impacting their quality of life. So you may have somebody that is just becoming more frail, and they're having more falls, more kind of aches and pains. So they might even be eligible for palliative care. If it's something you're interested in, if it's something you have a question about, I would encourage you to reach out to a palliative care program. Every program I know that supports people in the community, because it's different if you're in the hospital, but every program I know will provide a free evaluation. They can tell you whether you meet that criteria to enroll in their program and the ways in which they might be able to support you.
Great, thank you, Dr. Wilhoit and Jessica. And I think that you helped to kind of cover the kind of last question comment that came in around trauma injury.
There was a question.
Unless there's anything else.
Yeah, there's a question for Dr. Wilhoit about kind of how you separate your role out as a death doula and a palliative care physician, and why a person wouldn't just seek a physician who is a death doula so that it would all be covered.
I chose, I think it's my love and my passion, and where I feel the most connection, I would say, is at the end of life space, and being with individuals who are in that season. And for me, I am a physician, yes, and I am, board certified and fellowship trained in hospice and palliative medicine, which I love and I appreciate, and it's really meaningful for me. But for me, I think the doula work is, frankly, it's very much what I do and what I had done. I was a physician for 10 years before doing the doula work. And I would say for me, the doula work is just anything I can do to continue expanding what I can offer to individuals. And I think that the doula work for me, I don't want to say it's more meaningful, because I'm so honored. I think that I have a role as a physician that I'm so honored to have, and I don't want to take that for granted for 1 second. But I love with a doula, I can have the time to be with people, and I get to be present, and I get to be real. And yes, I obviously incorporate the two. I don't have like a doula job and a doctor job, like it's just woven together. But I think that the doula space for me is a way of just enhancing what I can offer to patients and families. I don't know if that answered the question.
Well, I'll just add to it that there aren't very many doctors who I think have gone out and become doulas. I can name one, and that is Dr. Wilhoit. So I think I'm sure there are others. I'm not saying there's nobody else, but I think it's pretty unusual. So I think to try to find a palliative care doctor who is also a doula, like, certainly strive for that. But I think, there are many phenomenal palliative care doctors who are not doula certified. And I don't know that it's really that you can't really bill for the doula part of the services. I think it's more Dr. Wilhoit incorporating the philosophy of a doula being very patient directed, and maybe she on her own time spends more time with her patients than an average doctor would. But you can't bill the services of being a doula just because you're a palliative care doctor.
I was just with a group of professionals that were telling me that they have sent their nurses and their social workers through a doula training program. So it's really neat to see that. I think, like you said, Kim, those philosophies of what is behind what it means to be a doula, and really focusing on this person and their support system and what brings them joy, that is a very special focus. And so incorporating that into any sort of clinical medical practice just it benefits everyone, just like the understanding the core principles of palliative care and incorporating that benefits all other types of care. So this overlap that we're slowly starting to see is really exciting and only benefits the people receiving that care.
Great. Well, thank you everyone who asked your very thoughtful and insightful questions today, and for our expert panel. Before we go into the final closing, is there any final thoughts that the three of you had that maybe you thought of that you didn't get to express before we close out today's webinar? Jessica, I'll start with you, Dr. Wilhoit, and then Kim.
As the social worker, I'm going to tell you, don't be afraid to ask. If it's something you've heard about, something you're interested in, you can do the research. You can assign somebody in the family to do the research for you, keep them busy. But don't afraid to ask the questions. Ask your care team what options are available for you. Ask them, I heard about this thing called palliative care. What can you tell me? What are my options? You don't have to wait for somebody to bring it up to you. So that would be my best advice is don't be afraid to talk about these things that are on your mind and to ask questions to get the care that you need and want and deserve.
Wonderful, Jessica. I wanted to say that, as Jessica said, don't wait to ask. That's probably no one, I don't want to say no one, I don't want to be cynical. I'm an optimistic person, but I would say that oftentimes it is not brought up by the physician or the team who's managing this person's serious illness. And so as a patient, as a loved one of a patient, the advocacy role, the voice, and being timid and not feeling that, that crazy mismatched hierarchy of, well, I don't want to tell my doctor what to do, but no, really, it's okay. I mean, and I want, if people take nothing else from this call, I want to just advocate that you advocate for yourselves and say, but I really do think it's important. And I know you may not think I'm ready, but I really do. I've had people with terminal and truly in the terminal stages of bad cancers be told that they're not ready for palliative care yet. And they're not even talking hospice, that they don't even want palliative care. The physician, the oncologist in that case has said, no, we don't need that yet. When the person has a knowing terminal illness. So I would say that advocating, using your voice is so important. The other thing I wanted to say is because of this, well, first of all, I'll say, oftentimes, and Jessica mentioned this before, if you're having trouble finding a palliative care program, oftentimes, like if you Google palliative care near me, it may not come up because oftentimes, most often, it's affiliated with a hospice. And so I know we're trying to really make the distinction clear, and there is a very clear distinction. However, there is a lot of overlap. And as Kim said, in the case of her mother-in-law, being able to transition from your palliative care team into your hospice team in the same group is phenomenal. And so if you are trying to find a palliative care program, maybe looking into the hospices in your area, and they may have some resources. And the last thing I wanted to say is because of this bad connection people have, or misconnection, I should say, mis idea that folks have about palliative care and hospice, there are a lot of particularly larger institutions transitioning from, in terms of, they're not calling themselves a palliative care doctor or a palliative care team. They're not even calling it a palliative care clinic. They're calling it oftentimes supportive care services. And so that is just a way to try to minimize the fear that people hear when they hear hospice and palliative care. So if you are, again, having trouble accessing palliative care, if you try even searching for supportive services or talking to your doctor about supportive services, that might be another way to work around. But please advocate for yourselves. And thank you all so much for taking the time. And Kim, thank you for your 10 years of service. And thank you for allowing us to be in this webinar with you. It's been such an honor to learn from you and to grow with you and to work alongside you. Thank you for your leadership.
Thank you. I'll just close out by saying, first of all, everything that Jessica and Dr. Wilhoit said were great, and they hit the key point that I was going to say, which is to advocate for yourself. Just a couple of resources on our website in the Our Issue section. There is a drop-down button that gets you to palliative care that goes through the ins and outs. I would encourage people as a follow-up to read that. Jessica and Dr. Wilhoit have done a great job of putting it together. It includes the link that Jessica mentioned that gets you to kind of palliative care resources in your community, and it does help to dispel the myth. So that's a great takeaway for anybody who didn't capture everything or didn't take detailed notes and doesn't want to go back and listen to the whole thing. The second thing that I would say is palliative care is a relatively new field. And so, as I think Dr. Wilhoit mentioned during the conversation, doctors sometimes don't know themselves. So don't be surprised or afraid if somebody says to you, oh no, like that is really when you need to use your voice. And then the last thing that I will say, not related to palliative or hospice care, but related to compassion and choices in general, is this is a tremendous organization that just does incredible work. And I'm looking forward to seeing what the organization does and continues to do long after I leave. And I will just say that the thing that makes all of our work possible are contributions and donations. So if you found this webinar to be useful at all, I encourage you to hop on our website and give a small contribution or a large one. We take any size to help allow this great work to continue to take place and this information to continue to get out to the community. So with that, I'll sign off to my final webinar. So thanks all.
Thank you so much, Kim, Dr. Wilhoit and Jessica, all for your tremendous leadership and participation in today's webinar, and for your leadership for the future of our movement to improve care, extend options, and empower everyone to chart their end-of-life journey. Thank you, Kim, for mentioning about donations, and that link will be dropped in the chat for folks. Also, please follow us on social media, and those links will be provided to you in the chat. And just thank you again, and we look forward to seeing everyone soon on our upcoming webinars. Have a wonderful rest of your morning and afternoon. Thank you.